This was actually the original. I'm showing this because this was the original description, a classic paper in 1966, which was by David Galton, who worked at the Royal Marsden in London. And he published this actually in the Canadian Medical Association Journal, which was very nice. And this was really an update, a 15-year update on patients he had followed in London as part of his PhD thesis. And even at that early time, there was very interesting reading, but he described two types of patients with CLL, those with aggressive disease and those with a more benign disease. And in fact, we now know that those are patients who've got either mutations or no mutations in the immunoglobulin gene. But the other thing he noticed in that paper was that these patients had low levels of gamma globulin. And the second point he made was that if these CLL cells are really cancer cells, what are they doing to the normal lymphocytes? And I think that he was a very, very smart man, and this was very insightful. And there we go. So if you look at the effects of CLL, I've shown here on the right normal lymphocytes, and these are an integral part of your immune system. There are B cells and T cells, and there are varieties. They're natural killer cells. But the B cells produce these proteins called immunoglobulins, and these cells are responsible for fighting off bacterial infections. And their T lymphocytes are important for fighting off fungi and viruses and also cancer cells. Now, CLL cells, since Galton made his description, it's been shown that the CLL cells can paralyze your immune system partly by releasing chemicals that suppress the good cells, but also by just the physical interaction of CLL cells with the T cells. They can paralyze their function. And that there's one drug, lenalidomide, which can actually reverse that phenomenon, and that's very important. But most other drugs actually suppress your B cells and T cells, so that actually taking chemotherapy may be good for your lymph nodes, but it's not going to necessarily improve your immune system. So if we go on and talk about cancer, there was the first major paper on second malignancies in CLL actually came from Winnipeg, a chap called Brian Weineman, who then was head of the cancer clinic in Victoria. And what he showed was that the risk of cancer in CLL patients was about twofold or 2 to 3-fold higher than in patients who did not have CLL or people who did not have CLL. And skin cancers are the primary problem. And we've subsequently updated this. We did a study in Winnipeg looking at a more updated group of patients and showed that this is not just because we follow our patients closely, but if you compare it with other lymphomas, CLL patients are different. They have this increased risk. It doesn't matter what your age is, your risk is increased, whether you're a younger patient or older, and it increases further if you get chemotherapy. So your increase is twofold, and then if you get chemotherapy as well, it's another twofold. Now, I'm going to talk a bit about skin cancer because this is so important. The earliest abnormalities that we look at when we check our patients is for what's called actinic keratosis. These are these little areas which are caused by sun damage. Many of you, I'm sure many of you, 25% of our patients have skin cancers, and far, far more have actinic keratosis. This is caused by sun. It is usually on the forehead or on your nose or the tips of your ears. And if it is not treated, it will progress to what's called squamous cell carcinoma of the skin. And this early abnormality can be easily treated by using liquid nitrogen. It's a spray, or we use what's called Effudex as well. And the next phase, if you don't treat it, is squamous cell carcinoma. And here's one of our patients with the tip of her ear. And this needs to be either radiated, but usually you do surgery to remove it. And these need to be treated because they can grow quickly and they can spread. The more common cancer that you will see is basal cell. These are the most common. And these are usually remain localized. Typically, most of the ones I see are over the nose. And they are different. You can see that they have this kind of rolled edge to their appearance as opposed to squamous cell. And then there's the, my slides won't work. There we are. Then there's, of course, melanoma. And these, again, are more common in CLL and need to be picked up early. And the last is a particular kind of cancer which is typically seen in CLL. It's not, this is the least common, but we have about 5 or 6 patients with this, and this is called a Merkel cell tumor, and it's caused by a virus, and again, it can grow quickly. Now, I'm emphasizing this because skin cancers are so important. They are so important. We have a dermatologist in our clinic. All our patients see a dermatologist in diagnosis or within a short while. And if they have any of these abnormalities, they are followed by her on a regular basis. So my advice to you is get checked by a dermatologist, avoid the sun or use sunblock. And then, of course, the other cancers which are more important are in men, lung, colon, prostate, and in women, lung, colon, and breast. And we strongly emphasize screening for these cancers. Our patients have colonoscopies. We have a smoking cessation clinic, and we are quite vigilant when patients come to us to talk to them about screening and have they had their screening tests. So that's just the first point I wanted to make.